Senator Pratt now joins me in the studio. Thanks for being here.
Thank you.
Insulin for some Minnesotans has become unaffordable, causing some individuals to ration their supply, which can be fatal, as happened to Alec Smith, who is named in the House proposal. You have proposed an Insulin Patient Assistance Program. How would it work?
So it's very simple. A patient would go out to MNsure. They would put in their information. MNsure would generate a patient program and a form that they would take to their doctor. The doctor would fill in their prescription information. They'd send it to the manufacturer. This entire process, we believe, can be done in 10 days, and somebody would be able to get help affording their insulin. We do know with Alec that he was having a problem affording his insulin. He was uninsured. This program would cover uninsured, but we're also looking at covering people with private plans and extremely high deductibles, and so we're working through some of those details right now.
And just to be clear then, this program kicks in for people at 400% of poverty, $50,000 a year for one person, or $100,000 for family of four, is that correct?
That's about the numbers. It's a little over $100,000 for a family of four. So if you had one person or two people on on insulin, then in your household, the amount for federal poverty level goes up. We thought those were pretty good positions. When I spoke with Alec's mom, certainly he would have qualified under this proposal.
Okay. Lawmakers have been grappling with this issue since last session, as you well know, and one of the sticking points has been who will pay for the free insulin. Your plan requires that manufacturers provide it free of charge to those who qualify. Are the manufacturers on board with this?
The manufacturers do have some concerns. They're concerned that we are expanding the eligibility maybe a little bit beyond their comfort level, but the fact of the matter is they would rather supply the insulin at a wholesale level rather than buying their drugs back at a retail level and subsidizing really what's become an inefficient distribution system with the pharmacy benefit managers and the pharmacies being involved. So what we're trying to do is cut the cost of the program by going direct from manufacturer to consumer through the doctor.
Okay, and then that brings up one of the concerns that was raised in the committee hearing on this, because there's a concern about whether doctors are really able to manage this, because the doctor would be working with the manufacturer to give the insulin to the patient, as opposed to going through the pharmacy, which is set up to do this. There's also a concern possibly about appointment times for people, because there can be long waits to get in to see doctors who do this type of prescribing. What are your thoughts on those two concerns?
Well, and I've talked to the doctors' organization, and I'll continue to have conversations with them. We're still not in agreement, but the fact of the matter is many doctors already have refrigeration available to them. They need it for their vaccines. What we're talking about is just some sort of little refrigerator to keep this insulin cool. As far as an appointment, these should already be existing prescriptions. It shouldn't take much more than a nurse filling in or a receptionist filling in the prescription information and having a doctor sign off on it. We're not asking for a lot. If we get the pharmacists involved, and by the way, the patient assistance programs that all the manufacturers use go through this very channel. So the doctors who already have patients on their assistance programs are already participating in this.
So you're trying to rely on an infrastructure that already does exist.
You talked about who will pay for it. You know, I had a couple of problems with the House bill when it came out. One was who would pay for it, but also the House bill would rely on a pharmacy benefit manager that would take us 9 to 12 months to get up and running, and then required a whole new infrastructure and a whole new department to be built. We're trying to cut cost and shorten the implementation time by using the existing delivery channel.
So the other criticism, though, that has been raised is that this doesn't have that emergency aspect to it. So if someone is just really at the end of their supply of insulin, there's no way for them to just jump in and get it. And advocates for either of these programs are hoping that whatever compromise can be found can have sort of the long-term benefit that you're laying out, but also an emergency aspect. Can both of those things be done?
They can. When I sat through the hearings at the House and even heard this during the session, we talked about insulin affordability. And the fact of the matter is the House plan provides a 90-day supply of insulin, but it has absolutely no answer for what a patient does at day 91. Insulin doesn't get any more affordable after the emergency program. Our goal is to get patients into their doctors and into a program before they hit crisis, before they need to get onto an emergency plan. Now, there's still going to, as I've talked to advocates, there's still going to be some that we need to do that for, and I think we can build an emergency provision in it. But our emergency provision should be much, much smaller than what the House proposal is.
There's still the underlying issue, however, of the skyrocketing price of insulin. What can be done about that?
Well, Senator Benson, I know, is working on some ideas, one including re-importation, so being able to re-import medicine from Canada back to the United States. I mentioned kind of a broken delivery system where the rebates that are being paid on insulin, rebates to pharmacy benefit managers and insurance companies, even the state of Minnesota. The state of Minnesota in 2017 made a profit on insulin because they got more in rebates from drug manufacturers than they paid out in reimbursements. That's what we're trying to avoid. We're trying to avoid that inefficient, expensive delivery system and go from manufacturer to patient.
Underlying this, is it that murkiness that exists about what the true cost of anything in our medical system is?
It really does, and Senator Draheim and Senator Jensen have both proposed transparency bills along that line. And I know in the Senate we passed some transparency. We also mandated that insurers couldn't profit from insulin. And I think that's why you're seeing every MNsure provider now cap their insulin copay at $25. So that is also where we started in July when the bipartisan working group broke up to where we are today. Even my proposal changed over time as the landscape, as the insurance providers stepped up and started providing insulin at a reasonable copay.
Now, you mentioned this. Senator Benson did have an amendment that was put on the HHS bill, and it prevents insurers from Minnesota from profiting off of the cost or the price of insulin. That will take effect in 2020. You mentioned how there are caps now among insurance plans at $25. So that will likely have an effect on the cost of insulin in the state. Do you think that's true?
It absolutely will. I mean, it makes insulin more affordable, and that's what we've been trying to do.
And for those people that don't have insurance but don't qualify, are they still stuck paying those very high prices for insulin?
If they're uninsured and they make over 400% of poverty level, so a family of four making over $100,000, there's a very good chance that they will end up. Now, they could also be qualified for some of the existing patient assistance programs, and I've talked to pharmacists who are ready to hand out information on those programs. Unfortunately, when you draw a line, whether it's at 400% or 600%, somebody's going to be left out. We're trying to cap at 400% of income. We figure we'll capture about 50% of Minnesotans that would qualify.
Senator Pratt, we have to stop, but I want to thank you so much for your time.
Thank you very much.